Hi, my name is Adie, and I'm a cardiology pharmacist at University of Michigan. Today, I'll be discussing anticoagulation in patients with COVID-19. There are several ways in which the COVID-19 pandemic may affect the prevention and management of thrombotic and thromboembolic disease. Both direct effects of COVID-19 or the indirect effects of infection, such as through severe illness and hypoxia, may predispose patients to thrombotic events. Hemostatic abnormalities have also been extensively reported in these individuals. Additionally, the severe inflammatory response, critical illness, and underlying traditional risk factors may all predispose patients to thrombotic events similar to prior coronavirus outbreaks. Let's focus a little more on those hemostatic abnormalities. The most consistent hemostatic abnormalities with COVID-19 include mild thrombocytopenia and increased D-dimer levels, which have been associated with a higher risk of requiring mechanical ventilation, ICU admission, or death. Disease severity is variably associated with prolongation of the prothrombin time and international normalized ratio and thrombin time, and variably by a trend towards shortened activated partial thromboplastic time. Additionally, a recent study looked at 3 cases with severe COVID-19 and cerebral infarction, with one patient having a bilateral limb ischemia. All these patients had elevated antiphospholipid antibodies. However, the authors note that these antibodies can also rise transiently in patients with critical illness and various infections. So whether these antiphospholipid antibodies play a major role in the pathophysiology of thrombosis associated with COVID-19 requires further investigation. But what are the consequences of these hemostasis parameter abnormalities? Tang and colleagues assessed 183 patients with COVID-19, 21 of whom died. Among the notable differences between patients who died and those who survived were increased levels of D-dimer and fibrin degradation products and PT prolongation. These hemostatic changes indicate some forms of coagulopathy that may predispose patients to thrombotic events. It is not known whether these hemostatic changes are a specific effect of the coronavirus or a consequence of the cytokine storm that precipitates the onset of systemic inflammatory response syndrome, as observed with other viral diseases. Additionally, looking at these hemostatic abnormalities, future research should focus on the optimal anticoagulation monitoring parameters for these patients, given that a lot of them will be on unfractionated heparin for VTE treatment. If the unfractionated heparin is being monitored by APTT, and that's shortened, adjustments to heparin to reach therapeutic levels may result in over-anticoagulation. We currently don't know the impact of coronavirus on anti-10A levels, and some institutions use these anti-10A levels over APTT to adjust heparin. However, from personal experience, we've had several patients with COVID-19 here with elevated anti-10A levels that made monitoring of unfractionated heparin especially difficult. Looking now at the incidence of thrombotic events in these patients, we see several studies. The first from Italy reporting a 21% thrombotic incidence, with the majority of cases occurring in the ICU. All ICU patients received thromboprophylaxis with low molecular weight heparin. 75% of patients on the general floors received prophylaxis. In a retrospective study from China, among 81 patients with severe COVID admitted to the ICU, there were 25% who developed incident VTE. Notably, none of these patients received chemical VT prophylaxis, and it was not stated whether they received non-pharmacological VT prophylaxis. In a study of 184 patients with severe COVID-19 from 3 academic medical centers in the Netherlands, 31% developed incident VTE. All patients in this study received pharmacological prophylaxis. However, underdosing was noted in 2 of the 3 participating centers. Looking at these values, we see these are much higher than the rate of symptomatic VTE events observed in the thromboprophylactic trials, not exceeding 3% in patients who were not on thromboprophylaxis and less than 1% on thromboprophylaxis. So given this high incidence of VTE, what are some strategies for prevention in these patients? Hospitalized patients with acute medical illness are at increased risk of VTE. Hospitalized patients with COVID-19, we know are high risk, and a lot of them have other comorbidities or respiratory failure. They may be bedridden or requiring intensive care unit. So they should really be receiving pharmacological VTE prophylaxis unless contraindicated. However, one of the current controversies is, while we know these patients should be receiving pharmacological prophylaxis, what dose of pharmacological prophylaxis should they be receiving? In this prospective observational study, the authors aim to characterize the coagulation profile of COVID-19 ARDS patients after establishment of aggressive thromboprophylaxis. Baseline testing was done on 16 patients receiving 4,000 units of nadroparin twice daily. We aren't really familiar with nadroparin here, but that's nadroparin 4,000 international units is equivalent to enoxaparin 40 milligrams. In this study, nadroparin dosing was empirically increased to 6,000 units or 8,000 units twice daily for those with a BMI over 35. Follow-up levels were available for 10 patients after 7 days of the increased dose. Notably, after increasing the dose of thromboprophylaxis, there was a significant time-related decrease in the viscoelastic parameters as listed here. Now, at some institutions, we may not have access to some of these viscoelastic parameters. Some institutions do, and it may include things like thromboelastography or TAG. TAG is currently under investigation for COVID-19 associated coagulopathy. One study in Italy looked at whole blood from 24 patients in the ICU due to COVID-19 and evaluated TAG parameters. Those parameters were consistent with a state of hypercoagulability shown by decreased R and K values and increased values of the K angle. However, we didn't have imaging on these patients to confirm thrombotic events in that population. So while TEG might be available in some institutions, we expect that it will show a hypercoagulable state in these patients, and we don't have good guidance on which levels may lead us to empirically anticoagulating them. So really more needs to be done before we use that more widely in this patient population. The authors in the previous Netherlands study that I mentioned also used an increased prophylactic dose in these patients after 1 month of treating them. The authors theorized that these increased doses may be required to overcome the dramatic elevations in levels of procoagulant factors that are not present in the standard post-op patients or hospitalized medically ill patients. However, due to the design of the study, the authors admit that they could not adjust the findings for the actual administered doses of nadroparin or study the effect of the changes in the local protocols for thromboprophylaxis. However, the authors suggest strict pharmacological thrombosis prophylaxis in all COVID-19 patients admitted to the ICU, and even suggest increasing the prophylactic dose towards high prophylactic dose, even in the absence of randomized evidence. While they used nadroparin in this study, they suggest using high prophylactic doses, such as enoxaparin 40 milligrams twice daily in these patients. While we have several studies here looking at low molecular weight heparin, the role of direct oral anticoagulants right now in COVID-19 prophylaxis is unknown. We know there are several studies for VT prophylaxis in medically ill patients, including studies looking at extended prophylaxis in medically ill patients. Those listed here uses oral betrixaban and oral rivaroxaban for up to 45 days after hospitalization. In APEX, there was no significant difference between extended duration betrixaban and standard regimen of enoxaparin in the pre-specified primary outcome of a composite of asymptomatic proximal DVT and symptomatic VTE in acutely medically ill patients with an elevated D-dimer level. In Mariner, rivaroxaban given to medical patients for 45 days after hospital discharge was not associated with a significantly lower risk of symptomatic VTE and death due to VTE versus placebo. So what these studies tell us is they did not reduce the incidence of symptomatic VTE in medically ill patients when continued for several days after hospital discharge. However, the role of extended VT prophylaxis in patients with COVID is unknown. Some theorize that these patients may benefit given a lengthy disease course that may increase the likelihood of immobility. If these are used for extended VT prophylaxis, D-dimer should not be used alone, but consider a validated risk score such as IMPROVE from Mariner to help guide decision making. Notably, in Mariner, as listed on your right of your screen, they use this IMPROVE score 4 or more to choose patients who are eligible for rivaroxaban, or IMPROVE score 2, 3, and a D-dimer more than 2 times the upper limit of normal. However, while DOACs may be beneficial in that they don't have a lot of monitoring, some have theorized that heparin may be more beneficial in the patient population given its anti-inflammatory function, which led some authors to study the utilization in hospitalized COVID-19 patients. This was a retrospective study in about 450 patients, 99 of whom received heparin, for which the majority received low molecular weight heparin for 7 days or longer. The doses used are on the bottom right of your screen. The authors used a 6 score, which was based on the SOFA score along with the platelet count and INR. Notably, the authors found no difference in 28-day mortality between heparin users and non-users, but the 28-day mortality of heparin users was lower than non-users in patients with a 6 score of 4 or more, or a D-dimer over 6-fold the upper limit of normal. Notably, the authors suggest to use anticoagulation, but if you look at this dosing, prophylactic dosing of low molecular weight heparin was used in most of the heparin users. So the outcomes of the study have led some to think we should be putting therapeutic anticoagulation on many of these patients if they have some of these risk factors. However, from the study, we can only really say prophylactic anticoagulation in these patients is probably beneficial, and we don't really know the role for empiric therapeutic anticoagulation at the moment. However, if patients do develop a VTE or we have high suspicion and we cannot test them, we do have some considerations for VTE medical treatment. A selection of agent requires consideration of comorbidities such as renal hepatic dysfunction, GI tract function, among others. Parenteral anticoagulation may be preferred in critically ill patients as it may be temporarily withheld and has no drug-drug interactions with investigational COVID-19 therapies. However, there are concerns with time to achieve therapeutic levels and increased healthcare worker exposure for frequent blood draws. Additionally, as mentioned previously, it may be difficult to ascertain if the levels are truly therapeutic if some of those hemostatic parameters are altered in these patients. Low molecular weight heparin may be used in those unlikely to need procedures, but renal function should be monitored closely and levels could be obtained if on for prolonged therapy. Additionally, dosing with obesity can get a little tricky, so that's where some of our levels may need to be obtained in that patient population. The benefit of DOACs include lack of need for monitoring, as well as the facilitation and discharge planning, but we should be cognizant of renal function and drug-drug interactions. For treating these patients, some are thinking that we should be treating them like a provoked VT or PE, so consider 3 months of treatment. But again, we don't have good guidance on the optimal duration at this time. Looking here at some potential drug interactions, on your left column are investigational COVID-19 therapies, and in the middle columns include warfarin as well as our newer direct oral anticoagulants and some considerations that we may need to take into our thought process when deciding the best agent for these patients. Some of the interactions include PGP inhibition, next list of agents such as apixaban, rivaroxaban, we need to be concerned for CYP3A4 as well as PGP inhibition. In summary, hospitalized patients with COVID-19 are at a high thrombotic risk. Consider VT prophylaxis in hospitalized patients with a potential higher VT prophylaxis dose used in ICU patients. The role of empiric therapeutic anticoagulation is currently unknown. In those patients who have developed a VTE or have a high suspicion of VT for which they're receiving treatment, consider utilization of DOACs in eligible patients to minimize monitoring and facilitating discharge. I know we talked about a lot of unknowns at this time, but hopefully with upcoming research, we'll get more answers. Some of the ongoing studies are listed here, and they deal with many of the common themes we discussed today, such as therapeutic anticoagulation versus thromboprophylaxis, standard versus higher dose thromboprophylaxis, some of those viscoelastic parameters that we mentioned, as well as some novel things such as nebulized TPA for these patients. Thank you for your time today, and let me know if you have any questions.